Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for August 26, 2021. Today's CME activity code is 483323. As usual, we record these and we put them up on our YouTube channel. We're getting much more quickly lately. This ought to be in a couple days. Go there, join our channel, and feel free to look at any of a number of other old conferences that we've posted. If you need to get on the mailing list, send one of us an email. We'll put you on the mailing list. We're glad to have as many people as possible. As usual, we have nothing to disclose. The cases have been de-identified. Some of the dates and other things have been changed, although this patient is quite aware that we're presenting her, and she's really quite flattered that she made our conference. So we had a nice chat yesterday. I'm presenting today. By the way, I want to welcome three. This is now interview time, and pretty much for the next 8 weeks, we're going to have a conference. We'll be off next week, but we'll have every week after that, we'll have a conference, and we'll have our, because it's interview time, we will have some residents that are looking at renal fellowship joining us. Don't worry, we won't call on you or anything. The wheel doesn't have your name on it. But I want to welcome all, and we'll talk to you later, but I hope you enjoy the conference. This is a case of mine that goes back a long time. I've only been taking care for 10 years, but it's a very long story, and I think there's a lot of instructive points to be made about this case and about lupus and overlap and everything else, and just how long someone can survive and do well with a disease such as lupus. And we've got some quizzes built in that we're going to see what people say. And there'll be a lot of breaks for discussion that the co-hosts will be involved in. Any questions you have, put in the chat. Certainly, if you're a co-host, you can pipe in at any time. We encourage that. So this is 42 years of lupus, a tale of serial renal biopsies. Not too corny. This patient is a 60-year-old white female who originally presented in 1977 at age 18 with swollen, tender knees, wrists, ankles, and elbows. She'd been receiving allergy shots mostly for hay fever, but she called her allergist, and he sent her immediately to a rheumatologist who diagnosed her with lupus. He drained her knee of quite a lot of fluid, apparently, and started on aspirin. Now, remember, this is a long time ago, 1977, before a lot of things were available. And I remember those days when we would treat rheumatologic disease with aspirin and follow their levels, and just trying to get low enough that they didn't get salicylate toxicity a long time ago. But she was eventually received Indocin, and then Plaquenil, and finally ended up on prednisone and some azathioprine, but she had some hair loss from the azathioprine, and so this was stopped. And I really don't have any records of her urine from those years. So I have no idea what was going on. I don't know what the standard of care would have been at that point, but it was what it was. I'm sure they were following something. I just don't have any of that. She had a child in 1984, which is complicated by postpartum pneumonitis, interesting, and a pericardial effusion, which also responded to a short course of prednisone. Presumably, this would be a flare or a relapse that's not uncommonly seen in pregnancy or postpartum. But I can't believe she had idiopathic pericarditis. Regardless, she did well until 13 years passed since the diagnosis, and then so she does really well without really on anything. Until 1990, at age 31, she had proteinuria of 1 gram and hematuria in the setting of what was considered normal renal function, although the creatinine was 0.8, and she's a small woman. Regardless, a kidney biopsy was done, which revealed WHO2 mesangial proliferation. That's all I know about it, was those 4 words. Prednisone was again given for a short period, but no other immunosuppressive medications were administered, nor did she receive maintenance immunosuppression, but she remained free of any extrarenal manifestations. Renal biopsy number 2 was done in 1991, a year later, for unknown reasons, but was reported as no change. And again, reports and slides for both biopsy number 1 and biopsy 2 were unavailable. So she believes she was off any medication until 2002, now at age 43, when she had recurrence of her proteinuria, and her creatinine slowly increased to 1.2. Kidney biopsy number 3 was performed. This time was read at a university hospital, and it was read as, again, this is all I have from the report, 16 glomeruli, which with 1 global and 3 segmental necrosis, but they specifically said no necrotizing lesions. So this was in 2002. She received no specific treatment from 2002 to 2011, at which time a new nephrologist told her she had CKD4 with a creatinine of 1.8 and at that point her urine protein to creatinine ratio was 488 milligrams per gram. Her urine had 3+ blood. She had a positive ANCA. Now, I don't know if it was ever checked before, but she had a positive ANCA from the rheumatologist. Now at age 50, 32 years after diagnosis, she came to Rush University Medical Center for a second opinion from rheumatology. So this is now her review of systems. This is now 2011. It was really nothing except for the pollen allergy. She specifically denied rash, fever, weight loss, arthralgias, gross hematuria. She felt actually pretty good and was shocked that she had this degree of CKD and was a little surprised no one had told her it was this bad. Her past medical history, lupus, hyperlipidemia. She had a tonsillectomy. She was on pravastatin, thiazide, and Cozar. She was allergic to Bactrim. There's a fairly strong positive family history of coronary artery disease, but no renal or autoimmune disease. Never smoked, drinks very, very little, and no drugs. She was G4P3, one spontaneous miscarriage. On physical exam, she's a thin white female, 125/75 blood pressure, heart rate 69, temperature 96, respiration rate 16. She was 5'5", 53 kilograms, and her BMI was 19. She looked healthy. She had nothing else really on her exam, nor oral ulcers, rashes, lungs were clear, heart seemed normal, soft murmur, and her joints looked fine, and she had no edema. On laboratory exam, sodium 139, potassium 4.5, chloride 103, bicarb 27. Her BN was 35 and her creatinine was 2. Her glucose was 91, total protein 6.3, albumin 3.6, LFT is unremarkable. I don't have lipids. Her urinalysis had a specific gravity of 1.008, pH of 5.5, 1+ protein, large blood and dipstick, and 25 to 50 red blood cells per high power field. No white cells. Her 24-hour urine had 1,000 milligrams of protein. Her hemoglobin was 11.9, white count was 5.2, her platelets were normal. Her serologic examination had an ANA of 1 to 160, homogeneous. Her anti-double-stranded DNA antibody was greater than 180. Her ANCA was positive with an MPO antibody greater than 100, and this was confirmed, although her PR3 was negative. Her C3 was mildly low at 75, C4 21, SED rate 46, CRP less than 5. Anti-SSA, SSB, RNP, CCP, Smith were all negative. Her hepatitis studies were negative, and her SIEP was negative. She was then referred to Rush University Medical Center Nephrology, moi. So this is quiz number 1. I want to know what people think. Would you, and we'll put the quiz up in a second, so everybody can vote except the co-hosts. And certainly the co-hosts don't shut the window because that will turn off the poll. So option number 1, I've seen enough. I would treat her empirically with standard induction therapy that was available in 2011 when we're seeing her 10 years ago. Or number 2, I would obtain biopsy number 3 from 2002 to review myself. Or option number 3, it's time for renal biopsy number 4. We'll give it a few minutes. So what we have, I think you can see this, we have 58% said time for biopsy number 4. 29% said get the biopsy to review yourself from 2002. And 13% said I've seen enough. I would treat her empirically with standard 2000 induction therapy. I'm laughing because, when we make these up, we hope that we'll have at least some equal distribution. And I'm very happy with this distribution. But the majority said go ahead and biopsy her. Next slide. So I want to open it up to the faculty now to talk about this. And I'm going to start with Bill, Dr. Whittier. How did you answer this, and what are your thoughts about each of these?
Yeah, I think I'd love to get the old biopsy just because that might give you some idea of what was going on then. But I think regardless of what that shows, there's some new features here and some progression. And so I think it is time for biopsy number 4. But in the old biopsy, it kind of had said focal and global glomerulosclerosis, and that there weren't any necrotizing lesions, but that's kind of what I would like to search for. Something caused the focal and global sclerosis, and there's a lot of different possibilities of those causes. One could be a segmental necrotizing lesions that have scarred over, leading to segmental necrosis and leading to scarring and even global sclerosis as well. And so you wonder if that's something that's going on. I mean, she has a positive ANCA, you know, she not that that's always necessarily, you need that to have a segmental necrotizing lesion in lupus, but yeah, I guess I'd like the old ones, but no matter what, I think it's time for biopsy number 4.
Well, so what's your number one answer?
3. I'm sorry.
3.
Try for biopsy 4. Yeah.
Time for biopsy number 4.
Yeah.
Dr. Corbett.
I mean, I agree with Bill. I think, you know, at this point, the last biopsy was what, 9 years ago, and we've got a lot of serologic activity right now. I mean, you know, MPO positive in lupus, you know, ANCA associated positive ANCAs in lupus is about a third. Yet we see a lot, you know, vasculitis that's not associated with ANCA in a lot of these patients. So it is interesting that she does have an MPO ANCA. Plus, she's, you know, serologically quite active with a high double-stranded DNA. And yeah, in the last biopsy you had, really all you had was chronic disease. There was nothing active to treat. I guess if all you see is chronic disease in this one, then at least you know that there's nothing specific from a renal standpoint you treat, and you treat the extrarenal lupus. But if you see a lot of active lesions, then I think that's going to be helpful too. And then, you know, the type of the lesion will be helpful, whether it's immune complex mediated for the most part, or whether it's pauciimmune. So I think there's just, in my mind, there's no way you get away with not doing another biopsy on her at this point before you try and decide what the appropriate therapeutic plan is.
Now, number 2 does not necessarily negate number 3, but that's, you know, got to have a certain amount of options. Dr. Glassick, you know, this patient has very active serology, high ANCA, hematuria, creatinine's climbing. Why not just treat her? You need to unmute yourself, Dick.
Well, I think that's a logical question, Roger. I wouldn't put a lot of faith in the anti-MPO positive ANCA in a patient with high titer anti-DNA antibodies because, as Jeanette showed a number of years ago, there is a very high prevalence of false positive anti-MPO when anti-DNA antibodies are present. And when you treat the serum of a patient with lupus who has positive anti-MPO with an enzyme against DNA, a DNase, the titer will often dramatically decrease. So I'm not sure that there's a rationale for doing a biopsy in a patient like this just because she has an ANCA. I think I'm more concerned about the change in the serum creatinine over time, and I wonder what is the lesion that's responsible for the progressive decline in GFR? That would be my principal concern, not so much to detect, you know, a necrotizing lesion of vasculitis. And treatment of this lesion empirically, I don't think would be a good idea. But I can see a potential rationale, but what would be the empiric treatment? Steroids alone, MMF alone? You know, it's a pretty open box.
Yeah, well, we can get to that, but you're absolutely right. So, I mean, I think you can make an argument for any of these. So let's go to the next slide. And the answer is obtain biopsy number 3, or that was my answer. And we were actually able to get it. And so let's take a look at it and see what they go. Again, like I said, obtaining that biopsy does not mean we're not going to do a biopsy number 4 by any means, but it might, depending on what we see. So we are going to spin the wheel
Give me a second here.
and see who reads biopsy number 3.
Let's see. Oops. There we go. Should be. There we go.
Good.
Yep.
Okay. Oh, great wheel. Who shall read the biopsy? Wild card. I'm going to put this on Dr. Corbett.
Give me a second here.
He loves lupus.
Click on the screen. Go ahead and click on the screen. Yep, you're controlling it.
All right.
Now, we only received one H&E slide from the third biopsy.
Well, that'll make it easy.
Go ahead.
You want me to advance it?
Here, I'll advance the slide for you here.
Sorry.
Actually, you'll have to advance the slide. Just at the bottom arrow. Yep.
So we have a low power of a single core, which looks like an H&E. We've got let me get my stuff out of the, we've got basically one glomerulus here. Again, this is very low power. The rest of this looks like medulla. It looks like we have a red cell cast here and some infiltrate here. This may be another glomerulus. It's more sclerotic, but there's, like I say, a little patch of inflammation. Is this the only picture you have, or you've got some higher power?
This is the only low power picture. Yeah.
I'm sorry. So I say you have some higher power. So now we've got a higher power picture of one glomerulus. This looks like it's probably the proximal tubule here. The capillary walls don't look that thick. The mesangium looks a little expanded and hypercellular in areas, but I don't see any necrotizing lesions in there, no scars, definitely no crescents.
Right. Yep.
All right. Another one, again, an H&E, it looks like. This looks ischemic to me, David. I don't know what you think, but it's all kind of collapsed down.
Yeah.
These blood vessels definitely doesn't look normal. We've got some arteriolar sclerosis.
Yeah. Mild arteriosclerosis. Yeah.
And again, this looks collapsed, but I don't see any necrosis or crescents or scarring. So another, I assume this is H&E.
Yeah. Right. Yeah. These are all H&E. That's all. We only got one slide.
It's just kind of dark. Again, it's kind of a funny cut. I don't know if this is a deposit or if it's a hematoxylin body. It's hard to really interpret much here because you're just getting a part of the glomerulus. And there may be some, ATN here. It's hard again to say, but I don't know, David, what do you interpret this to be?
Well, it's more at the area down and where the pointer is now, and it was a little more obvious when I had the slide in front of me. But I think that's a segmental necrotizing lesion. I see a little bit of chirectic debris in there. There's some fibrin that may be transitioning, to a scar. There's some cellular proliferation. Up at 11 o'clock, yeah, I'm not sure that if those are hyaline thrombi or fibrinoid necrosis, but anyways, I have to interpret this as an active type of histological lesion.
All right, I'll take your word for it. I mean, I guess this may be some TRX. It's just such a funny cut that it's just hard for me to make much out of it. I mean, I see proliferation, a lot of nuclei, and I guess this it's pinkish, but it doesn't look that much different than the rest of it. So if it's an active lesion, then it's an active lesion. There's one, that's the only one we've seen so far. I mean, that's a tubule. So So here's another glomerulus, another H&E. This one's at the edge with the Bowman's capsule stripped away. Again, these capillary walls look a little thicker. This almost looks like a scar here. I mean, it looks like there's a synechia. I don't know if this is the vascular pole, but this definitely looks like it's adhesion to the Bowman's capsule. And I'm guessing you're going to say this is another active lesion.
Yeah, segmental lesion. It may be transitioning to scar, but I wouldn't dismiss these as having no activity in the biopsy.
Okay, so we have a second active lesion.
Yeah.
The red cell cast, which we saw one on a lower power. Here's one, two. So the mesangial staining IgM 3+, interesting. So no IgG,
No.
kappa and lambda light chains 2+, so they're equal. C1, C3 was there, and trace C1q. And I assume we'll have an EM reading. So
Yeah, we have a couple EM images.
Interestingly, that there's no IgG in this anywhere, not even in the mesangium, from what you're saying from the report.
Yeah. This is from the report at the University Hospital.
So here we have a low power EM. Here is actually, now I've got to get, this is urinary space here. Here's a capillary lumen. You can see the fenestrated endothelium. Podocytes here look pretty good here as well. I don't really see any subendothelial deposits of any note. Here's this looks like another urinary space, podocytes that look pretty well spaced. There's no fusion that I can really see or effacement. Here's the mesangium. I think there are some faint deposits here.
Yes, yeah, focal small faint deposits.
You know, not a lot. Here's another loop. Again, processes look, the podocytes good. The endothelium, I don't really see any deposits per se. Here's the nucleus of the endothelium. Again, you can see the fenestrated endothelium really nicely here and here. So again, just some mesangial deposits to go along with the IgM, which is, again, kind of interesting that there's no IgG. Here's another one. And again, you see some faint deposits. There's a lot of cell processes in here, but I see some faint deposits here. Here's a capillary lumen. I think this is another capillary lumen. I don't see any subendothelial deposits in either one of these. Here's podocytes. This is a paramesangial area. The podocytes look good. Here's another capillary lumen. No subendothelial deposits. Podocytes, it's hard to say. There's not much that you can see. But again, not that bad, with the exception of a few mesangial deposits. So, well, I mean, based on David's description of those two glomeruli, you know, we've got a segmental necrotizing lesion here, which, interestingly enough, is only associated with IgM in the mesangium. I don't know how else to read that. How did you call it, David?
Yeah. I agree with you. That's how I interpreted it.
I mean, I find it interesting that there's, you know, no IgG whatsoever, and even the C1q was kind of weak. But that's kind of what we're left with.
And then, David, even though this wasn't a trichrome, were you able to estimate the chronicity or amount of tubular interstitial fibrosis?
Yeah, it was focal, less than 10%.
And Roger, remind me the creatinine at this time, because this was the older biopsy, right? This was, she was 1.2 here.
1.8. Oh, no, that was in 2011. This was the 2002 biopsy.
Yeah, so she was 1.2 here?
Yeah.
Okay.
So David, you're calling this off, that there's just the one core, right?
What's that?
You were showing me parts of one core.
Yeah.
And so that was the low power that we saw was basically it.
Yeah, so there was a total of 14 glomeruli. One was globally sclerosed, and then the two had those segmental lesions.
Well, fair enough then, because that the low power you showed only looked like it had one glomerulus in it.
Yeah.
Okay.
Well, what it's not is what it was read out as, obviously.
Say it
What it's
again.
what it's not is what it was read out as. Is it said no segmental inflammatory, no segmental necrosis, and I think
Well, they
that's
were
what it's
reading it
not.
as chronic, as basically, a chronic disease. There were no active lesions, and now it's being reinterpreted as having 2 active lesions.
Yeah. So how does that? I mean, what does that mean to you? But and um, more specifically, the absence of IgG. I mean, this patient has an ANCA, and we see pauci-immune. We see lupus patients that are very pauci-immune, but they usually have background mesangial IgG. And this patient has this ANCA. Dr. Glassick did bring up the point that maybe this is, just a false positive ANCA. But there's a literature of people. We'll talk about this later, of course. But there is a literature of people that are with lupus that are ANCA positive. So does that sway you towards or way to one of these diagnoses?
Like I said, that at least when I've looked at this before, it's like 25 to 30% of patients with lupus in general, all comers will have an ANCA that's positive, whether it's a false positive, as Dick alluded to, or real. I mean, the ANCA is positive now. I don't know what it was in 2002.
Exactly.
And so who knows what was going on in 2002 with respect to serology. I mean, the only thing that sways me is that her creatinine's gotten up to 2 now. She had now active disease in the past. And I still think we're stuck with trying to figure out how active is the disease now, or is it just all of the active disease is now scarred and we're dealing with chronic disease? I still think the biopsy becomes helpful.
So I have a question for David. This is Mario Rubin. David, as it was pointed out, there is paucity of electron dense deposits, no IgG. Do you think that the IgM is a real thing or is an example of entrapment? And the other issue, I recently heard a lecture by Dr. Jeanette on lupus, actually. He made the point that if you find necrotizing lesions in a focal area, such as in this case, that does not exclude the possibility that you have missed crescents elsewhere.
Yeah, I mean, there's always a possibility there's unsampled crescents. I mean, Dr. Corbett showed that, 20 glomeruli, statistically is a good sample, to exclude a focal lesion. There was only 14 glomeruli here. And then, yeah, I think the IgM is not trapping, those glomeruli, they have all open loops, and there are mesangial deposits there. It may represent lupus, but more importantly, I think the pathogenesis is that these are segmental necrotizing lesions rather than classic, immune complex driven disease.
Let's move this along. We got a lot left. So we're going to jump ahead now. This is when I saw the patient in 2011. So all this was before I saw the patient, but I got the biopsy in 2011. We just looked at it. So this is now 9 years after biopsy number 3. You're seeing her for the first time. The creatinine has increased over those 9 years from 1.2 to 1.8. Her ANCA is very positive. This is the first time tested as far as we know. And the double-stranded DNA is very positive. So I'm going to ask this question again. This will be a poll. I've seen enough. I would treat her empirically with standard 2011 induction therapy for lupus nephritis or ANCA-associated vasculitis. Or number 2, time for biopsy number 4. All right, well, unlike the last time, this is a little more swayed towards time for biopsy number 4. I think that's certainly reasonable. We'll talk a little bit about that, but I think it's certainly reasonable.
I mean, how do you not do a biopsy? Would you have been comfortable with going ahead and treating her empirically?
Well, next slide. Steve?
I'm the shill now.
Steve, yeah, no, but I mean, that's the question. I guess I couldn't talk anybody into empirically treating her. I don't think it's crazy, but I think you're right. I think that most people would want to get a biopsy. It's been a long time, but we saw a pretty bad lesion. Things are getting worse. Seems unlikely. And she hasn't been treated. So she had this necrotizing lesion for 9 years without treatment. It's kind of hard to believe that things are going to look good, but that being the case.
Well, if she had a necrotizing lesion 9 years ago and her creatinine now is only 2, things didn't move along very quickly. I mean, we talk about these people as having, rapidly progressive GN sometimes. Granted, we didn't see crescents, but in the segmental necrotizing GN, you see it too. I mean, it's been smoldering if it's been going on for 9 years. So, I mean, I think you're just as likely to find all scarred glomeruli as you are an active lesion.
I think that's fair. And if that's the case, if you're going to find all scarred glomeruli, would you not treat her?
Like I said, if there's nothing active in the biopsy, then I think you treat the extrarenal lupus.
Yeah, I think that is a very arguable point, both sides, and maybe we'll get to that because her creatinine is rising, and this is a sample issue, and what you said is
well, it's always a sample issue. If you have a good sample.
Well, yeah, but it's also the degree. I really meant to say the degree. So there's people that have 10% involvement, there's people that have 80% involvement, and there's a difference between those two, and a much higher involvement percentage is going to present clinically different than someone who has a very low percentage and is knocking off, a glom here and there. So
it sounds like you would treat her no matter whether you found an active lesion or not.
Well, let's see.
You think you might have missed the lesion.
You can ask me that later. Let's see. Next slide.
All right.
So we did obtain biopsy number 4. I'm kind of a duh at this point, but we don't need to spin the wheel. Steve, you get to read it again.
Give me a second here, Steve.
All right.
Now 2011, 10 years ago.
Go ahead, click on the screen.
Yeah.
You can advance. Yep.
All right, I'm getting better at this. All right. So now we have a trichrome. Was this read here? Was this done here?
Yes.
Must have been Bill that did this one. It's a nice size sample. So we've got a fair amount of blue staining material here. I say fair, probably at least 25%. I mean, you see this is all scarred, here's scarring, but then there are areas that are pretty good. I don't know what David called it, but
Yeah, 25%.
And we'll get a higher power to see what goes with the glomeruli and the other more normal areas, but we do have some more chronic disease. We've got glomeruli such as this on the H&E, which look fairly pristine. Here's the vascular pole. There is some mesangial expansion with some mild hypercellularity. Granted, this is down in the vascular pole, but even when you get out in the periphery, capillary walls actually look pretty good. And I don't really see any any scarring, segmental scars, and there's definitely no necrosis to my eye, or for sure no crescents. I'm trying to say synechiae, for God's sakes, Jesus. That said, here I think we have a synechiae with some, I'm looking at this as being hyaline. I don't know, David, if you're wanting to call that fibrin.
Hyalinosis.
Here's the vascular
That's
pole.
hyalinosis.
So we've got it out here. We've got a segmental scar. Again, some mild hypercellularity. Most of the cells look, some areas, and even mild at best expansion. This looks pretty good other than the segmental scar, which was probably that old necrotizing lesion we saw. Here we have a glomerulus. This looks a lot more active to me, for sure. Again, it's kind of a matter of the cut, but I think this is fibrin here.
Yep.
I don't really see, I'm trying to figure out if some of this is Caryorhexis. Most of these look like nuclei, but I don't know if these are some Caryorhexis. This may be here, but for sure, I mean, I think this is fibrin. You've got a necrotic lesion here.
At 7 o'clock, there's some caryrectic debris down. Keep
Right
going.
in
Yeah,
here.
down in there. Yeah.
And this is kind of interesting. Capillary walls here look a little thick. I don't know if we've got a wire loop here or not, but we'll for sure see on the fluorescence in the EM.
And then there's kind of a fibrocellular crescent off to the right.
Right in here.
Yeah.
Yeah, and this looks almost a little like fibrin here as well.
Yeah.
So we definitely have one active lesion. So I guess that was captured on this biopsy. This is a second lesion, same thing. I think we have a crescent here. And it's another segmental kind of necrotizing. Here's another area that looks necrotic with kerorexis, and looks like there's fibrin. So we've got two. Here we have a third. This is kind of a mini crescent, I guess, but you sure see, there's definitely a segmental necrotizing lesion here. Here's the vascular pole.
Yep.
Jump in anytime if there's something else you wanted to say,
Okay.
David.
Yeah, I agree with you.
I'm assuming these are all different ones. What is this? We're up to a fourth?
Yeah, this is the
More of the
fourth.
same. I'm assuming here, if we got a silver stain, the Bowman's capsule will be completely destroyed. Again, you see a lot of kerorexis.
Yeah,
Here's
so
the
those four.
here's a silver stain of one of the more normal looking glomeruli, I guess. You don't see any holes in the en-face views of the basement of the capillary wall. I don't really see any spikes per se. This is really very nice. I mean, you don't see any holes whatsoever. So unless this is like a Churg 1, I doubt there's going to be a superimposed membranous on this. And I don't remember, the albumin was normal anyway, and I forget what the proteinuria was, but I don't recall it being that high. So this looks pretty good, actually. Oh my God. Here we go again. The IgG is negative. IgA looks like a cast here that's, I mean, we don't even see any background. This is really negative. Here we go with the IgM again. Interesting. In the mesangium, at least I think that's where most of this is. More IgM and another glom with, again, a mesangial distribution.
Yeah. And then down at 7 o'clock was a segmental scar. Yeah. There was some trapping.
This is a trapping here.
Yeah.
But the rest of this, that's interesting. That almost, we'll see the EMs. I don't know if some of these look like they almost might be subendothelial, but we'll see what we find. C3, that's interesting too. I mean, this is trapped in a scar.
Yeah, I think so.
So even the C3 seems to be very focal in nature. Huh. And then we have our electron microscopy. Capillary lumen here. See the fenestrated endothelium nicely. The capillary wall is nice and thin. These foot processes are just beautiful. Even at low power, you can see they're beautifully preserved, all of them. Over here, this is all urinary space. Here again, here's the glomerular epithelial cell. Here's the podocytes. Here's a mesangial area. I don't see much there, but I'm sure we'll get a higher power. Capillary walls are pretty good in thickness. Again, urinary space, the podocytes look pristine. Here's the lumen, capillary lumen, and again, fenestrated endothelium. I don't know if we'll get a higher power of this to see if it's a tubular reticular-like structure. Another lumen, again, no subendothelial deposits that I can really see. This is looks like a paramesangial area.
Yeah, so there is on the left loop at the 9 o'clock, there's two small deposits. Yeah,
Right here?
right there. Yeah.
Okay, I mean,
And if you go straight over to the right, there's one. Yeah, right there. There's a deposit.
fair enough. I mean, is there anything, we got anything higher?
No, but that was it. They were just scant and trace.
So, we're
What's your diagnosis, Steve?
Vasculitis. She's got,
I agree.
she's got segmental necrotizing lesions. Give me a count here, David. How many gloms did you have? How many were scarred?
14 gloms, 6 globally sclerosed. And then we have 2 with segmental scars, and then another 4 with those necrotizing lesions.
So over half of them are, half of them are scarred, but we've got now 4 with very, very, very active Pauci immune-like lesions.
That's enough.
That's all. I had paused.
So I want to open this up. I mean, maybe it's a little a moot at this point, but I want to ask Dr. Gashty, since this kind of came up, would you treat her empirically, or is there so much scarring here that basically this is not a poll this time? I'm just curious, would you finally initiate maintenance protocol? Because she's never been on any maintenance therapy with MMF or Imuran, which was the treatment at the time for maintenance for lupus or ANCA-associated vasculitis, or do you treat her with standard 2011 induction therapy? Casey, what would you do?
I would induce her. I mean, she's got a lot of serologic activity, and she's got basically a fibrocellular crescent and a lot of necrotizing lesions. I would treat her as, I know she's not a fresh diagnosis of lupus, but I would treat her as a fresh lupus because she's never really been treated. She's already lost a significant amount of renal function. And so why would I treat her any differently than a freshly found lupus?
So Dr. Glassick, what would you do?
Tough case. I think I'd probably treat her with MMF and steroids.
Mm-hmm.
I don't think I would give her induction for vasculitis, but I certainly wouldn't criticize anybody who said, let's give her rituximab. But I think in light of the history and the serological findings, I'd probably give her a lupus style treatment.
So this is 2011. I don't know if you remember your dates of when things became popular or not, but do you know what you would have done in 2011?
Probably the same.
Okay. I don't remember when MMF really got that strong.
2009.
Okay.
2009 was the ALMS trial.
Okay. Of course you would know that.
So that it's an interesting point. I mean, in TM and the group from China, Dan Tan, I think that wasn't that in the New England Journal. That was around the same period of time. It's interesting, definitely MMF, but we're looking at, would you have treated vasculitis with MMF? Because I mean, to me, this looks like vasculitis. It's in a lupus patient, but it for all the world looks like vasculitis. And just as an aside, this whole, you keep bringing up the whole issue of maintenance therapy. Contreras's paper didn't come out until 2004. So I granted a lot of patients that we'd had with lupus, we'd put on prednisone and get them down to a very low dose. But I don't remember when the whole concept of maintenance per se became real popular, and Dr. Glassick could probably remember this, but I know Gabe Contreras's article was the one that really kind of set it into motion. That was 2004. So the third biopsy was 2002. But my whole thing is,
well, we're 2011 now, so.
No, I get that. And I personally, I think in 2011, I would have treated this like a vasculitis. And I don't know that I would have necessarily leaned toward MMF over cyclophosphamide at that period of time in a patient that I felt predominantly had a paucium vasculitis. And so I would have leaned toward steroids and cyclophosphamide.
And I think that's a kind of a very rush approach. It was certainly Dr. Lewis's approach. He was very slow to accept. This is 10 years ago. He was very slow to accept MMF as even induction.
Well, even Brad Robin in 2011 was still. I mean, he wrote a review about the whole issue of oral versus PO IV cyclophosphamide and lupus. I mean, a lot of the people that were involved with the lupus nephritis group, were fairly attuned to using cyclophosphamide.
Yeah.
And I
Let's
don't know
move
if
along.
really a contraindication here. The one thing that would cover vasculitis and lupus very, very well and has been studied long-term would be Cytoxan. And, the data on Rituxan even at this time for lupus was relatively weak, and it's still maybe not the greatest, although it is becoming better and better. CellCept for vasculitis at the time was a weak and clearly been a progressor. She's had, even though it's just smoldering, it's gone from creatinine to 1.2 to 1.8, and now she has crescents. And I think something needs to be turned off. So at this time, I would give her Cytoxan and high-dose prednisone.
Okay, let's keep moving. I have a little bit left here. So, I mean, this kind of gets back to this whole question: is it lupus or is it ANCA-associated vasculitis? Is it both? Does it matter? Is it false positive? And maybe it kind of depends on whether you're a lumper or a splitter. I've always been a lumper, and it kind of influences how I approached it. But Dr. Glassick is a strict dataist. You know, he wants to see the data on all this, and he would, you know, which you can never ever argue with. But as far as splitting, where I tend to lump. Next, and that gets into maintenance therapy as well when we get to this. But the next slide. So, what about necrotizing lupus nephritis with ANCA positivity? This was Glenn Markowitz had a real nice article in Jason in 2008. And basically, he just described the lesion. He had 10 cases that had lupus that were also ANCA positive. And this was kind of the typical lesion that they found with, if you'll see, I mean, most of the tuft here looks pretty normal. There's no proliferation except for this break in the basement membrane here with fibrinoid necrosis and fibrin spilling out into Bowman space and a nice, beautiful crescent there. And he also made the point that class 5 was very rare. So kind of describing it, you know, not too long before biopsy number 3 was this becoming more of an entity. And again, I really can't comment on this false positivity or whatever, but it is an entity. And it seems to have its own clinical presentation, which makes me think that it's a little bit more than a false positive. Next slide. So this is a real nice study that came out in KI in 2017 by Liz Lightstone out of London at the Hammersmith. And basically, they looked at a much bigger series of patients that were ANCA positive that had already had a clinical diagnosis of lupus nephritis. And they were trying to see whatever distinct histologic features and clinical outcomes there might be. So they had 254 patients. The majority of these were 225 were ANCA negative, using as their control. So basically, they had 32 ANCA positive lupus patients with nephritis that were also ANCA positive. Interestingly, not unlike our patient, 82% were MPO and not PR3. Next. And some findings that they found, it doesn't really surprise me in a way, but this is the filled-in squares are ANCA positive, the opens are ANCA negative, and you see more segmental pattern in those, much more like a vasculitis in the ones that are ANCA positive versus the ones that were ANCA negative. That's on the left, and then on the right again, looking whether or not it's, you know, hypercellularity. Now that the new term for endocapillary perforation, the endocapillary hypercellularity. The segmental actually in the ANCA positive did have a fair amount of endocapillary hypercellularity, but this was in the segmental. So, you know, it did appear to have a different pattern. Next slide. And here this shows the percentage of biopsies with necrosis, not surprising. Those with the positive ANCA had more necrosis. And those with ANCA positive had more crescents. So it implies to me that at least the ANCA is not just an innocent bystander. If ANCA has some influence on pathology, making it more of a segmental necrotic, crescentic kind of GN, at least she was able to demonstrate that in her comparison. Next slide. And this was the percentage of biopsies with subendothelial deposits. And it really doesn't a big difference here, but you know, the ANCA positive, there's a little, if you look at the ANCA positive, they tended to have more smaller compared to those with the ANCA negative. So again, implying it's a little less immune complex mediated, but not as strong there. And then there's, next slide, there's an editorial that came along with it, which put together this very nice figure, kind of putting it all together, saying, well, these are the 14% ANCA positive. They had very high anti-double-stranded DNA, but when they presented, they had higher creatinins, implying a worse outcome. They're much higher incidence of class 4, segmental, that is, more necrosis. Interestingly, a little more hypercellularity, which does surprise me. We did not see hypercellularity here in our case, and a tendency to more crescents. We might have missed it if we would have seen more glomeruli. I kind of doubt it. Our sample size was pretty good in the second one. And as I was pointed out, I think it was kind of a smoldering segmental necrosis all along. And again, less 5. And they talked a little bit about using, cyclophosphamide but the renal outcome was varied. And what they looked at, the renal outcome was worse in these patients, but when you correct for the fact that they started with this higher serum creatinine and their lesion, there was no surprise here. So it's not necessarily that the ANCA made them a worse outcome, unless the ANCA makes them worse lesion, but it wasn't, they did have a worse outcome, but it was explained by mostly the fact that when they caught them in a more severe form or pathology chronically. Next slide. So what did I do? This was 2011. We were using oral cyclophosphamide, probably independent of what I kind of thought. Again, being a lumper, I said, I'm going to treat this is pretty bad. I got to turn this thing off. I'm not going to take a chance. As my colleague, Dr. Casey, always uses, no regrets Cytoxan. We chose that path, and I gave her 50 of prednisone. 3 months into it, she developed PJP pneumonia. This was not, unfortunately, in my mind, automatically giving prophylaxis. She was Bactrim allergic, was part of the problem, but I could have given her something else. She did okay. I was planning on giving her 4 months, a little longer than I usually would for normal lupus induction. But that was based on the fact that the pathology was I was waxing and waning between, am I treating a vasculitis or am I treating lupus nephritis? I mean, we used 2 months of oral cyclophosphamide in the lupus trial and got away with most of patients. So, getting 4 months of oral Cytoxan is adding up. Anyway, at 3 months, she got PCP pneumonia. She was admitted. She had self-allergy, so we gave her dapsone and Cleocin. She did well, but then she got a rash on dapsone. We gave her Primaquine. She got a rash. We gave her atorvaquone, and she started losing her hair, but by then she'd recovered, and we were pretty much over the PCP. Fortunately, she did well. So now we're in 2012, we have to decide on maintenance. So I put her on MMF. That was well established. I felt comfortable with that, but she got severe diarrhea. Imuran, in the past, she got hair loss, and she was not willing to take it. And Rituxan was not really on my SLE, ANCA-associated vasculitis radar at that point. So what do? What is left? Every other day steroids? Anybody have any thoughts? She clearly needs maintenance because this has been going on, and the last thing we want to do is turn this off, and 3 years later she starts smoldering. Well, next slide. Go ahead. I'm sorry.
No, I was going to say, I mean, in the lupus study, you guys would, they tapered them down to what, 20 milligrams, and then converted from 20 daily to 20 every other day and maintained them on that for a period of time. So I guess the alternate, tapering to an alternate day prednisone may be one option.
And I saw a lot of those patients, because I followed them after the trial, and a lot of them ended up with hip replacements and knee replacements.
I saw, it's funny, I saw them too. I don't have to, I guess my experience with aseptic necrosis wasn't as high, but they definitely can get it. But I mean, you've already kind of gotten through everything that you would normally use.
So I wanted to show these 2 articles, just because I remember I don't remember when they came out per se, but I remember reading them much later. This is 78. I was in college, and then I was an intern here. But the point is this Dr. Fauci, this is how I knew of Dr. Fauci. We all know him, you younger people, know him from something else. But he was really the king of vasculitis at the NIH, and every few years they would come out with all their experience. And by this point in 1983, they already had 21 years of experience, and that was kind of the gold standard for what this disease did before a lot of multi-center trials. Next slide. So this was a study by the French vasculitis group in 2008 in New England Journal of Medicine. They compared azathioprine to methotrexate maintenance for ANCA-associated vasculitis. So me being a lumper, not necessarily a splitter, I'd already been using methotrexate as maintenance for some of my GPA patients that they had written about. So I felt that might be a reasonable option here. I did not like the idea of using alternate day steroids, and so I thought that was a very nice option. They had 126 patients, interestingly enough, again, this was pretty much biased towards GPA, but you can see they both did similarly well. So I think it established methotrexate as a reasonable option for ANCA-associated vasculitis. I don't know that this has ever been studied in lupus, and one could argue that that's an experimental therapy. But I was really left between a rock and a hard place, and so I put her on methotrexate. It's once a week, 15 to 25 milligrams. You use folic acid once 1 milligram a day, and you tell them to not to drink, and you follow their LFTs. Next slide. And this is what happened. I don't usually keep this kind of records, but I always did on her because she was so tricky. and I never wanted to lose track of it. This is my own little flow sheet. But here when she started, she had a double-stranded DNA of 180. Her MPO was greater than 100, and her creatinine was 2, and she had 3+ blood on urine. And so what do I follow? I follow her SED rate. I follow her double-stranded DNA. I follow her complements, and you can see they all sequentially get better. What was really interesting is the double-stranded DNA almost, within 2 months normalized. But it took almost, 6 or 8 months before the MPO antibody went away. SED rate came down and creatinine came down a little bit. I was more worried about, the lesion, not that it was going to get significantly better, but that I was hoping that it would not get worse. And what was really important to me was her urinalysis got better, and it's been without blood forever. And I think she's been in remission forever. I think she's been in remission for the last 8.5 years. My feeling is that she's on maintenance forever. That is arguable. We don't have the time to discuss that today, but I think she did really well. And the reason I wanted to present this case was really what, never underestimate what you can learn from someone else's renal biopsy. We always try to pull them and take a look at them. And clearly what else can be learned from a new biopsy? So I think all those answers were right. I like the idea of Cytoxan. MMF might have been fine. It really wasn't that inflammatory. Rituxan might have been a great option too, but it really wasn't, on anybody's radar, at least wasn't on mine in 2011. I could see using Rituxan now, quite frankly, as kind of an overlap therapy for whatever she has. And I'd like to open it up for anybody's last comments.
Even though there's so many new therapies out there, especially even with voclosporin and a lot of the new ones, it doesn't mean throw away all the old ones. This is a great case of how cyclophosphamide worked really, really well. I thought your maintenance choice was just really outside the box and amazing and great. And what a great way to keep somebody in remission when you don't have many options. And it's always something that I think rheumatologists always remember to think about methotrexate, but nephrologists don't always do. So wow, kudos, amazing.
Yeah, I have a couple patients that I've only gotten there because they couldn't tolerate anything else, and I've got a couple other lupus patients on it. And I'd also felt comfortable because I was using it I had several patients with sarcoid. There's nice literature using it for sarcoid. So because I felt very, much more comfortable with it. But you have to be careful. It can cause renal failure and can cause liver toxicity. And but I always say nothing's worse than renal failure. So you got to take your chances and be well informed. Anybody else have any other thoughts? If not, we'll wrap this up.
So Roger, as Dr. Corbett suggested, this was a case of MPO vasculitis, not of lupus nephritis, right?
Well, that's a good question. I think Dr. Glassick was arguing the other way around. Dick, what do you think this is?
Well, I think it's mostly lupus. I'm not entirely convinced that it's an MPO antibody-mediated vasculitis. Although I must say your final slide showing the correspondence between a decline in the titer and the improvement of the patient makes me have to think twice about that. This is a really amazing case.
Thank you. In the board, in the chat, it says she's still on treatment. Yes, she is still on treatment. I have no intention of stopping. I have cut back a little bit, especially when COVID came out. I've tried to cut back a lot of the immunosuppression on people, but she's been doing fine. And she's a little lady with a creatinine of 2.3. She cannot afford a relapse because she just, I'm sure her GFR is really, really quite low at this point. So. All right. Well, thank you, everybody. I really appreciate all the comments and I appreciate the interest. We had a new record attendance this week. Thanks. Please come back. And we'll be off next week, and then we'll be back in 2 weeks, and then we'll be going several weeks in a row. So be safe, everybody.